Welcome to part 2 in a series about constipation. Now, nobody likes talking about poo, but if constipation is left unchecked, it can really impair your quality of life. So in this video, I will be discussing the treatments used to relieve constipation in the context of palliative care and advanced organ illnesses. We will discuss how and why these treatments work, things to avoid, and in the latter part of the video, we will specifically address how we can prevent and treat opioid-induced constipation. Let's talk about it. Welcome to Palliative Care Explained, a channel aimed at answering your questions about palliative care. My name is Dr. Jonathan Wong, and I'm a palliative care doctor based out of Winnipeg, Canada. Please see the welcome video of this channel for my declaration that I do not have any conflicts of interest or any financial sponsors, and for the medical legal disclaimer statements. If you haven't seen part 1 of this series, I talked about the many different causes of constipation in the context of palliative care and advanced organ illnesses. I will leave a link in the description box below. Let's now talk about how we can relieve constipation. When you say relieve constipation, is there a specific goal in mind? What is considered normal? In the context of palliative care and advanced illnesses, this is a complicated question to answer, as it depends on how close a patient is to end of life. Let me explain. In otherwise healthy people, we can reference the Rome 4 criteria, where, in terms of the frequency of bowel movements, normal or not constipated is having 3 or more bowel movements per week. In the context of palliative care, however, it's not that straightforward. If a patient is still relatively functional, the Rome 4 criteria can still be applicable. However, as a patient's illness progresses towards end of life, and as their intake diminishes, their stool output will also naturally diminish. So one cannot expect frequent and large volumes of stool if one is not eating very much. Having said that, even if you are not eating, your intestines will still produce mucus and secretions that still need to be passed. Another factor to consider is, what were the patient's bowel habits like prior to having an advanced cancer or organ illness? What did they consider to be normal? What is considered normal must be individualized, and we must appreciate that the goal is a moving target that evolves as the patient's overall function and health declines. We can still apply the other Rome 4 criteria though. Ideally, we would still like to achieve bowel movements without the need to strain, without the presence of dry or hard stool, without the sensation of incomplete evacuation, and without any abdominal discomfort. We would also need to be observant for associated symptoms of constipation, such as sensations of bloating, new restlessness or delirium, new urinary symptoms, or overflow diarrhea, especially in patients who are less able to articulate their symptoms. So the take-home message: treatment goals and what is considered normal must be individualized to the patient and should be openly discussed with their medical team. Let's now talk about how we treat and prevent constipation. Treatment specific to opioid-induced constipation will be discussed in the latter part of the video. Let's start with the non-pharmacological treatments, ones that do not require the use of medicines. Lifestyle modifications, such as increasing one's activity level, are often recommended to the general public. Why? Physical activity and exercise stimulates peristalsis, which then facilitates having more frequent bowel movements. In the palliative care setting, however, many patients are either too ill or too fatigued to comfortably participate. With respect to dietary modifications, increasing one's fluid intake and dietary fiber are again common general suggestions. But in the context of palliative care, many patients will not tolerate eating and drinking more, and often can feel worse if they attempt to. Key point. In this context, exercise and dietary adjustments might be helpful to some, but by themselves are often not enough to fully prevent or relieve constipation. While on the topic of fiber, let's talk about psyllium supplements. Psyllium is a bulk-forming laxative often recommended for mild constipation. The indigestible fiber remains inside the intestine and absorbs water, thereby bulking up the stool and making it easier to pass. An important point I want to bring up here, though, is that psyllium must be accompanied with a lot of fluid intake. In the context of palliative care, though, many of our patients' fluid intake is limited. And when taking psyllium without a lot of fluid, the indigestible fiber can turn into a hard and sticky mass inside the intestine. And this can actually make constipation worse. So key point, in the context of palliative care, or in the setting where a person's fluid intake is limited, psyllium is best avoided. Your medical team may also provide suggestions for improving toileting posture, improving privacy, equipment to improve access to the bathroom, and strategies to minimize physical and psychological barriers where possible as it relates to toileting. As well, your medical team may wish to review all of your medications in hopes of minimizing constipation-inducing medication side effects. Now, sometimes we are asked about complementary therapies such as massage, reflexology, and acupuncture. These may be effective on an individual level, but the supporting research evidence behind these therapies, for constipation at least, is limited. As such, we do not broadly recommend these to everyone as a substitute for evidence-based recommendations. If you are interested in pursuing these, however, please also be aware that these can be expensive and may not be covered by healthcare plans. Let's now talk about pharmacological treatments. In the setting of constipation, laxatives are often a necessity, and this is especially true with opioid-induced constipation. The patient and the medical team need to work together as laxative choices, the dosing, and the frequency are dependent on the patient's preferences, tolerance, and response. The right balance is often a moving target, so frequent reassessment is a must. What are the different types of oral laxatives, and how do they work? Let's start with Docusate, which is an emollient laxative, better known as a stool softener. Docusate allows water and fat to more easily enter the stools, making it softer and easier to pass. Docusate, however, does not have a significant effect on peristalsis, so it doesn't actually help propel stool along. It only makes it softer. In the context of palliative care, Docusate, when used alone, is frequently not enough to relieve constipation. Furthermore, in the patients that I have looked after, many find Docusate pills difficult to swallow. So with these factors in mind, many palliative care physicians do not routinely recommend Docusate as a first line or to be used alone. But there are specific cases where it might still be useful, so best to check with your medical team. Let's now talk about stimulant laxatives, ones that actually stimulate peristalsis to propel things along. A common example of this is Senesides. It's fascinating how these work. The ingredients are inactive until it reaches the large intestine, and there, colonic bacteria break it down into the active form, which then stimulates peristalsis. My Senesides are prescribed to be taken in the evening. Why is that? This is done to coincide, timing-wise, with your body's gastrocolonic reflex. This reflex is triggered by the presence of food in the stomach. The stretching of your stomach triggers a hormonal and neurological response that leads to increased intestinal activity and urges to have a bowel movement. This reflex is strongest in the morning and explains why many people have urges to have a bowel movement right after eating breakfast or after their morning coffee. As it takes approximately 8 hours for senescence to work, taking it the night before allows for the laxative effect to line up with the body's natural gastrocolonic reflex in the morning. Let's now talk about osmotic laxatives. These work by drawing water in through osmosis from the surrounding tissues and retaining it inside the intestines, which makes the stools bulkier, softer, and easier to pass. The softer and more voluminous stool, in turn, stimulates peristalsis to propel it along. Common examples that are taken orally include lactulose, polyethylene glycol, or PEG 3350, and magnesium hydroxide. Of these, magnesium hydroxide might work the quickest, but is often accompanied with intolerable side effects, such as nausea, abdominal bloating, and cramping. Furthermore, it could potentially cause electrolyte imbalances, especially in those with kidney issues. Patient intolerance is also the main problem with lactulose, as many experience side effects such as increased flatulence, bloating, and abdominal distension. Lactulose also tastes very, very sweet, and many find that aspect intolerable. Having said that, there are specific instances where lactulose is effectively used and favored, so the approach must be individualized to the patient. For many, though, PEG 3350 is generally palatable and more gentle in action and better tolerated than other osmotic laxatives in the context of palliative care. The greatest benefit of PEG 3350, I feel, is that the powder can be dissolved in a person's drink of choice, and it doesn't alter the taste or flavor in a terrible way. The drawback, however, is that you still need at least a cup of liquid to dissolve the powder in. And for some patients, that can still be more volume that they can tolerate all at once. In some of my patients, I have found it effective to divide the powder dosage into smaller volumes of liquid that can be taken throughout the day. Makes it more approachable than requiring drinking all of it at once. What about patients who are unable to comfortably swallow? In those instances, we would need to resort to using rectal suppositories or enemas. It's invasive, less ideal, and most patients don't like the process. Commonly, bicocodal suppositories are used, as these can stimulate peristalsis and increase water content back into the stool. This can also be combined with glycerin suppositories, which work by lubricating the stool, allowing for easier passage. In more complicated cases of constipation, there are enema options with similar mechanisms as already described. Common options include normal saline enemas, osmotic microenemas, and sodium phosphate enemas. Understandably, enemas are the least desirable option from the patient's perspective. And by the nature of how these are given, enemas are messy and require help from family members or staff. Now, there are a number of scenarios where the use of suppositories and enemas would be inadvisable and potentially harmful, such as in patients with an increased risk of bleeding, those with rectal disease, those with low platelet counts, or those with inflammation of the intestinal walls, to name only a few. So even though many suppositories and enemas are available as over-the-counter medications, I would encourage you to speak to your medical team prior to using them. Let's now talk specifically about how to prevent and treat opioid-induced constipation. Now, early on in my training as a palliative care doctor, I was taught a saying: the hand that prescribes the opioid prescribes the laxatives. Opioids cause constipation in just about everybody, albeit to varying degrees. Here, prevention is the goal. Take-home message: unless there are medical reasons to not be on a laxative, everybody taking opioid analgesics, even weaker ones such as Tylenol No. 3s, should also be taking regular laxatives in order to prevent opioid-induced constipation. Okay, so which laxatives should I be taking to prevent opioid-induced constipation? Canadian and European expert consensus groups suggest the use of a stimulant laxative, either alone or in combination with an osmotic laxative, in order to prevent opioid-induced constipation. In practice, patients prescribed an opioid analgesic should also be prescribed Senosides to be taken regularly. Taking it regularly is a very important key point. Depending on the patient's history and predisposition to constipation, PEG 3350 can then be used in combination with Senosides. The dosages and the frequency of these would need to be adjusted in order to best achieve a balance between bowel movement goals and patient tolerance. Frequent reassessment is required. Does this always prevent opioid-induced constipation? Unfortunately, no. In some rare cases, even with careful monitoring and dose increases of the laxatives, patients can still become constipated. A more common scenario are patients who have gotten really behind on their laxative use and are now experiencing severe opioid-induced constipation. In those cases, or in treatment refractory cases, there are relatively new medications that work specifically in opioid-induced constipation that may provide relief. These are called peripherally acting mu-opioid receptor antagonists, or PAMORAs. How do PAMORAs work? In the central nervous system, opioids bind to specific pain receptors and activate them, leading to analgesic effects and pain relief. However, there are also pain receptors, specifically mu-opioid receptors, located outside of the central nervous system and throughout the body, including the gastrointestinal tract. So, specific to this topic, in addition to their effect on the pain receptors found in the central nervous system, opioids also activate similar receptors found within the intestine, directly causing slower intestinal movements and increased fluid absorption. And this is why you get constipated from opioid use. How do PAMORAs work? These also bind to the same mu-opioid pain receptors in the intestine. But here, because the shape is different, it blocks the receptor instead of activating it. This action then prevents the opioid from being able to bind to and activate those pain receptors. In doing so, normal intestinal motility can occur again. Note that PAMORAs do not have an effect on the pain receptors found in the central nervous system, meaning they do not interfere with the pain control properties of the opioid. Here in Canada, there are only two approved PAMORA options, methylnaltrexone and naloxegol, although their availability and drug coverage varies greatly between the provinces. At time of filming, there is a third PAMORA, naldemidine, that has been approved for opioid-induced constipation in other countries, but has not yet been approved for use here in Canada. The use of these relatively novel medications should only be used in specific circumstances, and generally only when other options have been exhausted. So please discuss the options with your medical team or seek the consultation of a palliative care specialist. As with many new medications, these can also be relatively expensive, unfortunately. So what's new and on the horizon in the treatment of constipation in palliative care? Currently, researchers are looking at using medications with laxative properties that work differently than the stimulant or osmotic mechanisms described earlier. Among these include lubiprostone, a chloride channel activator found in the small and large intestines, and precalipride, a selective 5-HT4 serotonin receptor agonist that can increase peristalsis. Both of these are more typically used to treat idiopathic constipation in adults, but its role in the palliative care context and in opioid-induced constipation is still being assessed. To summarize this video, We started our discussion by talking about non-pharmacologic strategies to relieve constipation, such as increasing activity level, increasing fluid and fiber intake, reviewing medications for constipating side effects, and mitigating barriers to toileting. In the palliative care context, though, more often than not, we need to use laxatives, and we discussed the different types of laxatives and explored how they work to relieve constipation. We then discussed strategies to prevent opioid-induced constipation and the use of PAMORAs in more severe or treatment-refractory cases. I hope this video was useful in helping you to better understand constipation in the context of palliative care. Thank you very much for watching. Hope to see you next time.